A case was referred to me today and it was pretty interesting. I thought I'd share it with you. So it was a lower premolar re-RCT. The canal was not completely filled. It was a pretty straightforward case. It had just single canal, single root. So I thought I'd finish the case in 15 minutes, max a half an hour. I can just remove the GP right away, irrigate it and then place some dressing and I'd be done. But the case took almost an hour for me. So what really happened was that as I removed the GP and placed my 10K size, the file didn't go beyond middle third. So it was stuck at the junction of middle and apical third. Now this was very typical. Um, I could see a patent canal in the apex, it was visible. But there was a little bit of radiolucency in the junction of apical middle third. The radiolucent thing didn't appear like a file separation. It could be, but even if it's a file separation, it would have been like a very small file where the tip might have chipped off. But it was not typical separation kind of a thing. I tried further. As I was moving my file, I felt like I was hitting a rock, and that was a typical sign. There was a ledge. So I'll tell you the protocol I followed to negotiate the ledge and get the patent canal, clean it and obturate it. So for me to treat a ledge, the important thing is my armamentarium. What goes into treating that ledge? Main ingredient of it is EDTA irrigant. No, it's not your RC prep, it's not your EDTA gels or endoprep RC which you use, but an EDTA irrigant. So first I thoroughly irrigate my canal with EDTA and I let it sit there for about a minute. So that EDTA will react with the dentin, the hard dentinal chips that might have got stuck in the canal and the ledge area. It slightly softens the dentin for me. And then once the irrigation is done, I go in with my 10 size K file. It can be a 10 size K file or a DFinder or a C pilot file, C plus file. But for me in this case, I went with DFinder file of 10 size. I took my DFinder file and I was going in a balanced force technique. I was doing anti-clock and clockwise motion very gently. I've tried for about a good 3-4 minutes, but my file was not moving further. It got stuck there. So now that raises a new challenge for me. What was it? There is something more than a ledge. So the ledge didn't just go sideways. It was not a straight canal and the ledge went sideways so I can straighten it and get back in track. But rather, the canal had a slight curvature. There was a small nub that was created or probably previously present, and the dentist has straightened the coronal part of the canal. So now my job is to identify where can I get patency. So I use the slop technique. Based on my slop technique, I felt the calcification was either on the buccal side based on the slop or on the mesial side of the canal. So the two directions that was patent for me, or the two directions I should focus more on, was either distal or lingual. So now I go in with my K file. I bend the tip a little. I don't make it a 90-degree curvature, but just a slight curvature in my K file. And I slowly try and negotiate in the distal direction as well as the lingual direction. Each time I move up and down and try to get that path where my file can go in. So that's where I found a catch. And from there I negotiated little further. Not till the apex, but till the end of my ledge. So once I have negotiated through the ledge, I've bypassed it. That's where I stop filing with my hand file and then get my rotary glide paths. Not your 20K, 25 files, it's less than 15.4. 15.4 is the maximum. So I go in with my glide path and prepare the canal exactly to the point beyond my ledge. Not further, I'm not going deep down, I'm not engaging my file as much as it goes. But I only negotiated 1 mm at a time, not more than that, an mm at a time. So one thing that I'll be very cautious about when I'm treating a case with the ledge or a calcification is to be very patient take your time. If you don't have time in this appointment, you can recall the patient. But if you go in a hurry and try to reach the apex as early as possible, there's a high chance you'd either perforate the tooth or you would either break your file in the apical third. So now I went 1 mm at a time and bypassed through the ledge with my glide path. And once that point has been reached, I get back again with my K file and I start filing till the apex. I confirm the apex with my apex locator, and once that's done, that is when I again go back with my glide path and reach the apex. Then usually we are in a hurry because it's a single canal, and now that I've negotiated, I can go with bigger sizes and bigger tapers. But teeth, especially in a retreatment case, the apical, the dentinal tubules must have been blocked. It's hard like a rock, and the more pressure you apply, the more your file would screw in and break. So to avoid breakage, now I go with my 20 size, 25 size, and then 30 size. I don't skip sizes, and I try to do all of it in 4% taper, and then the final file would be a bigger taper or a bigger size. But never skip sizes when you are treating curved canals or teeth with ledges. So this is how we negotiate a ledge or any kind of calcification. But why did that ledge again occur in the first place? It is important to know that so we can prevent it in our cases. So most likely the clinician must have thought like it's a single canal, it's easy to do, so let me go in with a bigger size. So he must have used a bigger taper, a bigger size. So the problem with the bigger size files is that they're not very flexible. So they would not follow the curvature or path of the tooth, rather straighten the canal. So the file did not go according to the curvature, that little bend that was there, and it went into the curvature and screwed in. So one tip to prevent such ledges is don't use bigger sizes in the beginning. Always create a glide path, either with your hand files or with your glide path files, and in a very slow motion. The start of your root canal should take some time. Invest good time in access opening and negotiating the canal. Once you understand the curvature, once you understand how the canal is, that's when you can go in with the rotary and bigger sizes. So always be careful, always be patient while treating any tooth. Don't take for granted that it has just single canal or it's just an anterior. Every tooth is worth saving and every tooth requires your time. So please don't hurry while doing your root canal. I'm Dr. Sahiti. I hope you found my video informational, and if you want to see more such videos which are case based, then please do subscribe to my channel which I give down below. You can also follow me on my Instagram, and please do hit the bell icon so you can get a notification whenever I upload a new video. So looking forward to learn more with you, share my experiences and learn from your experiences. Please do comment whatever you feel, give us updates, and let's keep our dental community alive and thriving. Looking forward to learn more. Bye bye.